Stretch, do as you want, and I'm going to introduce the next speaker, who's another Belinda, but Belinda Wang this time. And Belinda is a PhD student at the Institute for Musculoskeletal Health. Come on up, Belinda, because we're going to get started straight away. You're going to talk about the comeback trial. So, you happy to talk while people are standing, or yeah. Sit down when you've had your stretch.
Thanks, Dana. I'll get right into it. So, a lot of you will have heard Louise speak about the trial this morning, so I'm just going to do a really brief recap here. 512 adults with mobility limitations took part in this 3-arm randomised control trial, which had a 6-month intervention period. So there was a coaching group who received an initial physiotherapy assessment, followed by fortnightly telephone health coaching calls by trained physios. A texting group who received a single physio health coaching call and then was supported through unidirectional text messages, and then a waitlist control group who received the texting intervention after 6 months. The trial found that at 6 months, those in the coaching group achieved a higher step count than those in the other two groups, and there was a more pronounced difference when comparing the coaching to the waitlist control group. And there was no evidence of a difference between the texting and waitlist groups. Over the 12-month period, the changes that were made in step count were maintained in the intervention groups. So now knowing that the intervention had a clinically meaningful impact on physical activity levels, we can turn now to thinking about the future implementation of this intervention. And an important piece of that is considering how the intervention might be funded or resourced. The decision makers who might be interested in funding this intervention are often working with scarce resources that they need to decide how to allocate, and ultimately their goal is to be able to maximise health benefits while minimising the associated costs. So by conducting this economic evaluation, we can better understand whether the comeback intervention represents value for money and hopefully help to inform some of those resource allocation decisions. The key question that we're wanting to answer is, from the perspective of the Australian Healthcare and Community Funder, what is the cost effectiveness and cost utility of the coaching and texting interventions when compared to waitlist control? Our primary time horizon will be at 6 months, where we'll be comparing the intervention groups to control as well as to each other, and we'll also look at 12 months, where we'll be comparing the intervention groups. As we are conducting a full economic evaluation, we'll be considering the costs and outcomes together. So when it comes to the costs, firstly, we're interested in intervention delivery costs, and examples of this relate to staff time for delivering the health coaching, as well as any equipment or materials that were required to deliver the interventions. In addition to this, we also want to look at downstream costs, which in our case are the costs that are related to health and community service use by the trial participants over the follow-up periods. Looking at downstream costs can help us to understand where there may be associations between participating in the intervention and changes in health and community service use, and also make sure that we're capturing any unintended consequences of participating in the intervention. When it comes to outcomes, we are interested in physical activity levels indicated by step count for our cost effectiveness analysis, and then the quality adjusted life years measured using the EQ5D5L for the cost utility analysis. The EQ5D is a multi-attribute health-related quality of life instrument, and so can be particularly useful for decision makers when looking to compare outcomes across a range of different areas of health research and a range of different interventions. Costs and outcomes will be combined to calculate incremental cost effectiveness ratios, both for the cost per additional person achieving a meaningful improvement in physical activity, as well as the cost per quality adjusted life year gained. Early analysis is showing that intervention costs are around $1,010 per participant in the coaching group, and $240 per participant in the texting group, with staff time being a big driver of these costs. As I mentioned, the evaluation is ongoing, but in helping us to understand the cost effectiveness and cost utility of the comeback intervention, the results will help to inform the potential for future implementation of this program. Before I wrap up, I want to acknowledge the comeback trial team led by Leanne Hassett and Kathy Sherrington, and also thanks to all of my supervisors, of which Marina, Kathy and Vanessa are here today for all their support on the project. Thank you.
Go you, spot on time, well done. Just before we move on to the next one, I'm going to follow Dana's lead, get you all to stand up while I introduce Ella Cooper, exercise physiologist on the Centre for Strong Medicine at Concord Hospital, and we'll be talking about staying strong after strong. I'm excited about this. Post-discharge exercise behaviour in older adults. Up onto your toes if you're comfortable with it, and then you can take a seat.
Good afternoon. Thank you for the opportunity to present today. My name is Ella Cooper and I am an exercise physiologist at the Centre for Strong Medicine within Concord Hospital. Today I will be discussing post-discharge exercise behaviours in older adults, but specifically looking at exercise continuation in patients 3 months post-discharge from the Strong Exercise Physiology Service. Chronic disease and frailty contribute to functional decline in older adults, but exercise can work to improve strength, balance and function. The Centre for Strong Medicine at Concord Hospital is a multidisciplinary outpatient service integrating geriatric, exercise physiology and dietetic care to optimise functional outcomes for older adults. The exercise component of the service involves patients performing individualised resistance training and challenging balance exercises in a supervised group environment. Patients typically attend the service once to twice per week for up to 8 to 12 weeks. However, this can be flexible depending on the patient's situation. As we only work with patients for a short period, our focus is on education and empowering them with the skills and confidence to keep exercising after discharge. We know that patients engage well in our program with high attendance rates and improved functional outcomes. Exercise continuation post-discharge has many known benefits, including upholding these functional improvements. Prior to this project, we had a limited understanding of post-discharge exercise behaviours. Therefore, our aim was to understand post-discharge exercise behaviours and identify opportunities to better support ongoing exercise. Between February and August 2025, patients were provided with a questionnaire when they attended their 3-month post-discharge medical review with their treating geriatrician. The questionnaire used multiple choice and short answer questions to capture self-reported exercise participation following discharge. A total of 154 patients completed the questionnaire with an average age of 82 years. 65% of respondents were female. The results were surprisingly positive. 89% of patients reported continuing to exercise in some capacity. This is a significant statistic. At the initial assessment to join Strong, a majority of our patients have had no prior exercise in their life. So to have 89% of patients reported ongoing exercise 3 months post-discharge is significant. Looking more specifically at exercise frequency, over half of the patients who reported ongoing exercise indicated that they were exercising on 3 or more days of the week. This is in line with the World Health Organization's recommendation that older adults should perform physical activity on at least 3 days of the week. Overall, these results suggest that patients are highly motivated and are exercising at a frequency likely to deliver meaningful functional benefits. Looking more specifically at where patients are exercising, the majority of patients indicated they were exercising independently at home. This is not surprising, as patients are given a home exercise program when commencing in the Strong program, so it makes sense that they're confident and comfortable performing this exercise in their own environment. 41% of patients reported exercising in a supervised environment, such as a group class at a gym or community centre. Given our environment is supervised, it is interesting that only 41% are exercising under supervision. Looking specifically at barriers and facilitators, motivation is not the problem. Patients reported a strong intention to continue exercising, with an average likelihood score of 7.5 out of 10. Cost, transport, and limited awareness of available programs were commonly reported barriers to participation in more supervised exercise options. To summarise, of those who have participated in the strong service, 9 out of every 10 remain active following discharge. However, engagement with supervised community exercise options remains underutilised, with the majority continuing to exercise independently at home. Since this analysis, we have commenced another project to partner with consumers to improve our discharge planning. This is currently underway, but hopes to understand patients' discharge preparedness and confidence. Using consumer feedback, we then hope to improve resources and processes to better support sustained exercise participation. Thank you.
Thank you very much, Ella. Well done. Very nice study. Please be upstanding and on one leg, if you can, while I introduce our next speaker, who is Megan Swann, occupational therapist and co-author of the Stepping On program. Megan, you have 5 minutes. One last speaker after that, and then we'll move swiftly to the theatre.
Hello everyone, my name is Megan Swann, and I want to thank you all for the opportunity to speak today. Firstly, what is Stepping On? I'm very grateful for everyone else that's talked before me because they've explained what the program's about. I'm the co-author of this amazing evidence-based falls prevention program, and I have been involved with it for 28 years now, so I'm not going to let it go. As health professionals, we all want to deliver and achieve good outcomes for older people. Stepping On is not a set of lectures that anyone can deliver. It is how the information is delivered that makes it work. The program is evidence-based, and over time changes creep in as we have multiple users doing it. Fidelity coaching is a great practice that aligns with the program as it is established from a large amount of evidence base. Okay, so also very happy for the people that come before me that work in the southwest Sydney area. As I only have 5 minutes, I'm going to go right into this. I had a partnership last year with Southwest Sydney Primary Health Network, which is as you can see, a very culturally, linguistically and socio-economically diverse area, which has the largest urban Aboriginal community group in metropolitan Sydney. There's an area from Bankstown to Barrel, so very diverse, and encompasses lots of LGAs, and it has a very, I was shocked by the statistics that in 6 years' time in Camden, there's going to be 151% increase in falls in their area, which is incredible. The statistics are mind-boggling. The Southwest Sydney Primary Health Network had a tender out for people to deliver the Stepping On program in their area, and Catholic Healthcare was successful. In the tender, applications were commissioned to provide Fidelity coaching, and I provided the Fidelity coaching to the successful tender person. So why do Fidelity coaching? We have found here and in the US over time, program drift can happen. If the program is altered, it ceases to be evidence-based and will not deliver the desired outcomes. There's a history behind this, is that after we ran the groups here in Sydney in 2000, the Americans came over, bought a manual, went back and delivered a program and just read the manual, and they did a pilot group and they found there was no reduction in falls just by reading the manual. So the Americans, who are pretty tenacious, what they did was they carried out quite a lot of studies, and the biggest was the largest Fidelity Delphi study to find the key components of stepping on. After these research findings, and you can look them all up, there's lots of studies the Americans have done, they're all on www.steppingon.com, they changed their practice, and it showed a large reduction in falls. And how they changed their practice was they got... some of the key... they went into the key elements of why stepping on works. There's on the website, there's lots of Delphi studies on the checklists, and they changed their training. It was mandatory now. You just don't buy the manual. You have to be trained. Also, too, they found that if you had Fidelity coaching, it helps. And Wisconsin Institute of Healthy Aging ran them. Anyway, any more information, you can talk to me. I've only got 1 minute. This was done. How did I do it? I went and saw the people, and I talked to them, and I gave them, the facilitators, I gave them the checklist. We talked about the checklist. I coached them. This is just some of the areas that I'm really whizzing through, how diverse the area is. This is the Vietnamese. I did, they're all bilingual. There was 4 Vietnamese groups that I visited. There was Fairfield, Vietnamese group. There's Oakdale, big rural community. Great Southwest, very big area. Ageing population. Liverpool, 62% increase in falls. It's incredible statistics. Narellan, I did an Arabic group in Narellan. Southwest Wanderers, Lamia. I completed 16 Fidelity coaching tests. Coaching, and I'll just, as I haven't got much time, I'll just read out the quotes. I asked people how you felt about the test. They were scared for me to visit. I think they thought I was just checking on them, I don't know, like a school teacher. And what they said was, reflecting on your Fidelity visits, I do believe they were very helpful and allowed me to reflect on my practice and delivery of the Stepping On program. As a facilitator, it was always been my priority to deliver the best program possible for the clients, my groups. The second person said the Fidelity visits, while initially I felt anxious about, were a positive self-reflective and educational experience. I enjoyed and have benefit from sharing of the information. All facilitators were very happy to be mentored. Some of them had been facilitators for up to 10, 12 years, and they even found that there was little things they were changing their practice. It's just over time. Everyone does it, little shortcuts and things. So it was very proactive. And the last one, to show you how diverse it was, so we're going down from Vietnamese right down to Barrel. This is the Barrel area. Very beautiful area, but very rural, and they've all got their problems too. So over to you.
Thank you, Megan. We're going to keep with the same pace, and we can have Luiza Rampi Pivotto, who's a PhD candidate, Institute of Musculoskeletal Health at University of Sydney and Sydney Local Health District, talking about the interventions for preventing falls in older people who have presented at emergency departments. Keep with the pace.
Thank you very much. Okay, hi everyone. My name is Luiza. I'm a PhD student at the University of Sydney, and today I'll be presenting the protocol for a review of interventions for preventing falls in older adults who have presented to emergency departments. So we know that falls and fall-related injuries represent a serious healthcare concern, as they are closely linked to increased morbidity, disability, hospitalization, institutionalization, and even mortality. The emergency department is often the first point of contact with the health system after a fall and manages a large number of these cases. Older adults who present to the emergency department after a fall are at high risk of falling again. Data shows that around 22% will fall again, and around 42% will revisit the ED for any reason within 6 months. So despite this, these patients don't usually receive the care needed to prevent future falls. And although the primary role of the ED is the management of acute care needs, clinical guidelines recommend that healthcare professionals assess falls fall risk and initiate prevention strategies. However, these recommendations are still not well implemented in routine practice, and the evidence supporting them remains limited. We do know that falls are preventable, but there is still uncertainty about which interventions are effective for those who present to the ED after a fall. So the aim of this review is to assess the effect of interventions for preventing falls in this population. So this will be a systematic review of randomized control trials. Very briefly, in terms of the population, we'll include studies involving older adults and also younger individuals with chronic health conditions who have presented to the emergency department. For interventions, we'll include any intervention designed to reduce falls. These might be single, multiple, or multifactorial interventions. For comparison, we'll include studies that compare the intervention with any other intervention, usual care or no intervention. And finally, for outcomes, studies that reported data on related to falls. So this is the protocol, but we've already explored the available evidence on the topic, and I thought I would share it today. We manually identified 17 eligible randomized control trials. Of these, 14 evaluated a multifactorial intervention, which means that the participants received 2 or more strategies, and these strategies were tailored to their individual fall risk profile. And 3 evaluated single interventions. So 1 evaluated a fall risk increasing drugs withdrawal, the other was home fall hazard reduction, and the third evaluated an exercise intervention. In terms of where the intervention was delivered, only 2 studies initiated the intervention in the emergency department, and in most studies it was delivered after discharge. So in this slide, green indicates the intervention was effective, and we only explored the results for the rate of falls and the risk of falling. Blue indicates no significant difference between groups, and no color means that these outcomes were not assessed. So overall, multifactorial interventions delivered in the community as well as exercise appear to reduce the rate of falls. And for the risk of falling, most studies found no significant difference between groups. Again, these are exploratory results. We also identified 3 ongoing trials, 1 currently recruiting and 2 not yet. So to conclude, this review responds to a recognized gap in practice. So at the end, we expect to synthesize the evidence on falls prevention for older adults who present to the emergency department. I would like to acknowledge my supervisors, Katie, Marina, and Vanessa, and also my colleague Charlotte, who is presenting in another room. Thank you.
Thank you very much, and that brings our session to a close.